This is going to be the first of two parts of talking about this is going to be the first of two parts of talking about pediatric respiratory patients. We're going to do the lower airways. I'm going to be doing a video on pediatric upper airway presentations sometime in the near future. We'll start with asthma, the big one, but keep in mind that the pathophysiology I'm going to describe here plays a role in pretty much most of the lower airway pathologies that you encounter in dealing with pediatric patients. Asthma, you're probably familiar with its triad of symptoms. You get inflammation of bronchial smooth muscle. This narrows the airways, bronchoconstriction. Then there's goblet cell formation. These are cells that help to produce and secrete mucus, and then mucus production. Here's a model of a bronchiole. Keep in mind the kids have really narrow lower airways to begin with. They are very susceptible to lower airway illnesses and pathologies. See this bronchiole here. It's nice. It's non-inflamed. It's clear. It's not occluded by gunk. Air flows very nicely and directly through this nice, beautiful, clear bronchiole. And this lovely, gorgeous flow is called laminar flow. And that's what we want. Let's look at what happens to the airways in asthma and how it screws up the laminar flow of air. You get inflammation. This narrows the airway. Then you get hyperplasia of goblet cells, and then those goblet cells secrete mucus, and that clogs up the already inflamed and occluded airways. Laminar flow goes away, and the patient has this turbulent airflow in the lower airways that isn't necessarily knocking anyone's socks off when it comes to getting oxygen molecules to the alveoli. However, the even bigger problem is getting air out of the lungs. Remember, you spend more time in the respiratory cycle exhaling than you do inhaling. Well, in asthma, it takes even longer for exhalation to happen because all of this crap in the airway and the swelling, but the patient doesn't have time to exhale fully before they need a new breath. Old air can't get out, and then the patient has to take another breath, and this is what is called breath stacking and air trapping, and this is also known as autopeep. The result is that you get these hyperinflated lungs that look like they are overfilled balloons that are ready to pop. The novice may think like, oh, look how beautiful these air-filled lungs are, but they're actually too damn big. They are way overfilled. This is all retained air, carbon dioxide that hasn't exhaled, so the kid is going to be hypercarbic. While hypercarbia is not a good thing, it's important to know that children tolerate hypercarbia like little champions. What kids do not tolerate is hypoxia. So when you are treating these little buggers, focus on the oxygenation. The pulse ox is your most important diagnostic tool. Also, of course, look at the patient and look for other clinical signs of hypoxia rather than zeroing in and chasing the shiny ball of the end-tidal CO2 that everybody loves to proselytize about how awesome it is. It's good, but focus on the pulse ox, way more important. Moving on from asthma, bronchiolitis is the bane of pediatricians during the winter. It's usually due to RSV. It's an infectious inflammation of the lower airways, classically most common in kids under 2, but last year's RSV, nuclear RSV, affected kids of all ages. These kids present like they're a snotty, sick kid. It's an asthma-like presentation. You'll hear wheezing. You may hear some crackling and popping in the lungs. Make sure you undress the kid and look at their abdomen so you don't miss retractions, belly breathing, etc., etc. And again, we focus on oxygenation. Normoxia is the goal. Interestingly enough, despite the wheezing and bronchiolitis, albuterol doesn't work on bronchiolitis. You can do humidified saline, and if the kid is sick, they do really well with heated and humidified high-flow nasal cannula. These kids are also going to be dehydrated as fuck. They're already dehydrated because they're sick and they don't feel like eating or drinking. But when they are tachypnic and dyspneic, they exhale tons of moisture. And since kids compensate really well, they may not show signs of serious dehydration until it's too late. Kids also get pneumonia quite commonly. Interestingly, one of the number one symptoms of pneumonia in the child is abdominal pain, often accompanied by nausea and vomiting. So you get a kid with nausea, vomiting, abdominal pain. Yes, you do your abdominal assessment, you palpate the abdomen, make sure you do a good head to toe assessment, and be sure you whip out that stethoscope and listen to lung sounds. And of course, always ask all the normal assessment questions like fevers. Have they been around other sick kids? How's the eating, drinking, peeing? Blah, blah, blah.